Hello everyone. Today we are going to discuss a few things about the evaluation of chest pain in the emergency department, specifically focusing on the things that we look for in the history to help us decide whether this particular patient is looking like a case of ACS or less likely to be a case of acute coronary syndrome. Now, why is this topic important? Well, chest pain is a pretty common presentation in our emergency departments, and we are broadly classifying chest pain into either life-threatening causes of chest pain or non-life-threatening causes of chest pain. Now, life-threatening causes of chest pain, what we have to understand first of all is that life-threatening causes of chest pain does not only mean ACS. It can be other life-threatening causes like pulmonary embolism, aortic dissection, pneumothorax, etc. And even things like pneumonia can be very severe as well. So don't be fooled into thinking that the only life-threatening cause of chest pain is ACS, because other life-threatening causes are also there, and they can actually be even more tricky to diagnose compared to ACS. But in this particular talk, we are going to focus mainly on ACS. Non-life-threatening causes include your gastroesophageal reflux disease and your chest wall related pains, like any kind of muscle pain of the chest. So those are obviously not life-threatening, and they are going to get discharged very quickly. But the problem is that it is very difficult to actually differentiate life-threatening and non-life-threatening causes of chest pain. And esophageal pain can actually sound very, very similar to the usual myocardial pain as well, and they can be very difficult to differentiate. So that is the whole problem with the management of these patients, is that no one single factor can actually allow safe discharge. So what are the things that we actually look for in evaluation of chest pain? We look at the history of the patient, whether it is sounding like a typical or an atypical chest pain history, the demographics, the age, sex, and relevant past history. The look at the ECG, of course, and you look for the cardiac biomarkers. Usually we look at the troponins. And you do serial troponin sometimes if needed. You can look at various risk scores, like your heart score. And sometimes in certain types of patients, you might actually admit the patient to do some kind of stress testing as well. And CT coronary angiography and diagnostic angio. So those are things that we do in patients at high risk or at intermediate risk of ACS, depending on the various score. So if at high risk, you are obviously directly go for angio, and if at an intermediate risk, we might consider doing CT coronary angiography. So by definition, ACS means a rise and a fall of troponin levels. So that gives you an idea of the myocardial necrosis that is happening. Stress test basically does not look for necrosis, that look for stenosis of the coronary arteries. And CT diagnoses plaques, whether it leads to coronary stenosis or not. So if you basically need the ECG and a troponin to diagnose ACS, you cannot just diagnose based on just your stress testing and your CT, and the angio will help you diagnose the culprit vessel. The problem is that ECG findings can be subtle. So people who get discharged from the emergency department wrongly and die, up to 70% of them actually had misread ECGs in the in the emergency department, as per the literature that I mentioned here. So you have three types of ECGs, broadly speaking. You have a diagnostic ECG, you have a non-diagnostic ECG, and you have a normal ECG. So there are different ends of the spectrum. So diagnostic ECG, new ST elevation, new ST depression, T wave inversion, which is pathologic, and new infarction Q waves. All of these things, when you see them, you are definitely not going to say that this is a normal ECG, and you will take them very seriously if it's a patient coming with acute chest pain. Non-diagnostic ECGs are tricky and they are very common. So they are old or non-pathological Q waves, secondary SCT changes. For example, if the patient is having LVH or LBBB or something, minor non-dynamic SCT changes that you are not really sure what the significance is, and whether sometimes the ECG is changed from the prior ECG, but it's still not diagnostic of acute coronary syndrome. So those ECGs fit into the umbrella term of non-diagnostic ECGs, and obviously then you have normal ECG in which everything is completely normal. So if you look at the data and for all the patients who have an acute coronary syndrome, And in this particular the study looked at around 11,000 patients with chest pain and around almost 2,000 patients with an MI. Around 6% of them had a normal ECG. So around 6% of patients had a normal ECG and an acute MI. And if you're considering non-specific ECG changes and acute MI, that happened in 23% of the cases. So what does this mean? Almost 30% of the cases, you had either normal or non-specific ECG findings, and still the patient had a myocardial infarction. So an ECG cannot rule out a myocardial infarction. So, what are some of the other risk factors that we look for? One is age. The older a patient gets, the more likely the patient is to have a myocardial infarction. So, obviously, a 20-year-old, generally speaking, does not have the same risk as a 75-year-old coming with chest pain. Male sex is at a higher risk compared to female sex. And all of the other risk factors that you will learn from their Framingham study and all, they are more important for patients who are less than 40 years of age compared to more than 40 years of age. Why is that these things like smoking, hypertension, diabetes mellitus, dyslipidemia, family history of chest pain, all of these things are great, but they are more relevant for patients who are younger. Because after you cross a certain age, then anybody can have an acute MI, regardless of risk factors. So these things are very good for diagnosing coronary artery disease, the OPD and all, Framingham heart study, etc. But in a patient presenting acutely to the emergency department, they don't actually make any difference, much of a difference, I should say, to whether the patient is at risk for an acute MI or not. Unless the patient is actually less than 40 years of age, because a 35-year-old with these risk factors is going to be at much higher risk than compared to a 35-year-old with absolutely no risk factors. Now, another problem is that the classical teaching about the classical chest pain doesn't always apply to the emergency department. So the classical chest pain is substernal, which gets worse with exertion, and it is relieved with nitrates. Unfortunately, these things are not particularly useful, diagnostically speaking, when it comes to the emergency department. So, risk of myocardial infarction with the type of chest pain. What do you think? What type of chest pain is at higher or a lower risk with for an acute coronary syndrome? So it turns out that as per the data, almost all of the different types of chest pain are having more or less the same risk of MI. So burning, pressure, blah 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 blah, all of them have more or less the same risk of MI. There is only one type of pain that actually reduces the risk of MI by somewhat. And I'm sorry, that is not burning type of pain. It is actually pleuritic type of chest pain. Pleuritic type of chest pain is the only type of chest pain that actually decreases the likelihood of MI compared to the rest. Again, it's not zero, but it is still reducing the risk of MI. And the risk is different if it is partially pleuritic or if it is completely pleuritic. If it is very typical pleuritic type of chest pain, that means patient is taking a deep inspiration and feeling a knife-like pain in the one particular side of the chest, and that is having almost 0% risk of MI as per the literature. But if it is only partially pleuritic, you're asking the patient whether if you're having pain when you actually take a breath and they'll just shake their heads. Well, that doesn't really decrease the risk by that much. Another thing that actually reduces the risk of MI by a little bit is whether it is reproducible on palpation or not. So obviously the patient is having pain on palpation, that tends to favor the diagnosis of a musculoskeletal etiology of pain. But if it only partly reproduces the pain, remember, even in acute MI, if you touch the chest and ask whether it hurts, even patient with MI will tell you that it hurts. Only if it is completely reproduced, does it significantly reduce the risk of MI. But again, it is not 0%. So you can still see cases where patients who had chest wall tenderness had an acute coronary syndrome. Coming to radiation, obviously radiation to both arms, that is the most dangerous and specific thing, and it is actually more common with radiation to the right arm, more specific compared to the left arm. Now, coming to atypical cases of MI. So, atypical presentation of MI, that is without chest pain, without the typical chest pain. Around 33 patients of MI, including your SME and NSME, in this particular study, they diagnosed it with CPKMB. 33, 1 in 3 patients did not have a typical chest pain. Now, this is more common in elderly patients, female patients, and diabetic patients. Now, coming to the which factors actually increase or decrease the risk of ACS. So, if you have a higher odds ratio, that means it's more likely to be MI, and if it's lesser, then it is less likely to be MI. If it is around one, then it is completely useless to decide. So, you see, one thing that can be useful is that if it is exactly the same as a previous summit, that can help you see that perhaps this patient is again having a repeat infarction. Worse with exertion does not change it by that much. Odds ratio is around 2.1. If it is on the whole, if you take everything together and if you feel it's typical for ACS, that is significant. And if it is atypical for ACS, that is also significant. So one particular point in isolation, not that useful, but taking all things together, then it might give you a good idea of whether the patient is at high or low risk for ACS. This is why I always stress that it is important to take a good history and decide what the actual risk of the patient having an ACS is, rather than just trying to focus on one particular detail and trying to use that to the entire treatment decision. Now, other studies, what are the most important things that will help you decide whether the patient is having MI? The positive likelihood ratios are best with, again, most of the best findings are with the ECG findings only. ST lesions, ST depressions, new conduction defects, T wave inversions, U waves, etc. Best history finding is radiation to both arms. So that is the best thing. Now, radiation to either arm, that is also that is moderately useful. Then diaphoresis, again, even though we see a patient chest pain with diaphoresis, it's a very scary thing. Diaphoresis by itself obviously can happen with multiple other things like, hypoglycemia as well. So overall, it's not going to be that great if you look at the studies. And associated with exertion is 2.4. So it's not as good as you might think. And when it comes to negative likelihood ratios, associated with exertion is even worse. It is zero point 0.8, so it's almost 1. So why is it this useful? Because you see, patients who get acute chest pain, they do not go to the gym. They go straight to the hospital. So it is most often going to be pointless to ask them whether the pain is worse with exertion or not, because generally they're not going to try and exert themselves. They're going to get themselves to the nearest hospital as soon as possible. So association with exertion is not a very useful thing in the emergency department. Great in cardio OPDs, not that good in the emergency department. Things that can actually help you decrease the risk of ACS. So basically, normal ECG, pleural type of chest pain, and positional type of chest pain. Chest pain changes with different postures. Obviously, that again points towards a musculoskeletal cause of chest pain. Another common pitfall while trying to diagnose or rule out ACS in the emergency department is therapeutic trials. Unfortunately, these are very commonly misunderstood, and they are used in the wrong way in the emergency departments in a lot of places in the country. You see, response to nitrates is not helpful to diagnose ACS. Most of the studies generally show that it's like equivalent to using some kind of placebo. So just plain with the nitrates, it is not useful to rule in or rule out ACS. Similarly, response to antacids. Again, this does not rule out ACS. There are various case reports of patients being given these various GI cocktails like mucian gel or etc. and having some pain relief. Now, there are various theories why this might be. One of the most likely is that patients who are having chest pain and an acute coronary occlusion, they can spontaneously reperfuse for a little while. And if you give some medication during that particular time, you might think that that particular medication worked. And if you are giving some kind of GI cocktail, you might fool yourself into thinking the patient actually had GERD. And you will discharge the patient, that the patient will re-occlude their artery after a little time, and the patient might die after discharge, which is a nightmare scenario for any person working in the ED. So again, beware that you antacids and response to antacids does not rule out acute coronary syndrome. And there was a systematic review, even though there is not enough studies to do a systematic review, which again showed that you cannot reliably exclude ACS based on response to antacids. What about previous normal stress test? Again, these do not really rule out ACS if the patient is again coming with acute chest pain. But a previous normal angiogram, if it was truly normal, then it is highly unlikely that the patient will develop significant coronary artery disease within the next 5 years. But sometimes by normal people actually mean non-obstructive lesions, which are 20 to 50% blocks. So they can actually fissure and ulcerate and lead to an ACS. So you have to be careful about what actually a normal means when it comes to a previous normal guy. So in summary, what are the low risk features? When it comes to position of the chest, the center can be MI, to the right can be MI, to the left can be MI, to the far left can be MI, but only to the far right side of the chest, unlikely to be MI. Unlikely, not impossible, but unlikely. None of the things I have discussed completely rule out MI. There's really literally nothing that can rule out MI based on history and physical examination alone, but you can get an idea. Pain primarily abdomen could be MI, but the chances are less obviously compared to chest pain. Pain lasts only second, so patient had pain for 2 seconds on getting up in the morning. Quite unlikely to be MI. On the contrary, pain that persists in the ED more than an hour, pain that recurs in the ED, again, more likely to be MI, more likely to be associated with complications. And obviously, if the pain is improving with exertion for some reason, then that's definitely not MI. So, more low risk factors, obvious reason for patient having chest pain, like some chest wall trauma, etc. Obviously, that rules out MI most of the time. But GI etiology is never a clear alternative diagnosis. GERD is always a diagnosis of exclusion in the emergency department. Always remember this. Other low risk factors are obviously palpation repeating chest pain, fully pleurotic chest pain, changes positional chest pain, pain that can be localized to a single fingertip. That is probably unlikely to be MI. MI pain is generally more diffuse. You cannot point it to a one particular point in the chest and say that is where my pain is usually. And stabbing type of pain. High-risk features similar to prior MIs, substernal poorly localized types of chest pain, brief, unexplained dyspnea, worsened with excision. If it's there, then it does increase the risk by somewhat. And radiation to both shoulders or both arms and diaphoresis, these are things that will increase the risk of ACS. So I hope you have a better idea about how to evaluate patients with chest pain from this talk. Thank you.